Hello and welcome to today's AAHA webinar, Denial Prevention, the Pathways to Success. I'd like to introduce our speakers for today. Melissa Harbert, the Executive Vice President of Operations at BLS Revecore. Melissa has more than 25 years of revenue cycle experience with more than 10 years in home infusion industry for a large nationally publicly traded provider. During her time in the home infusion space, Melissa was a regional director of over 20 branches in 8 states, then went on to be a part of a mergers, acquisition, and integration team, completing over 12 acquisitions. For over the last 10 years, she spearheaded the development of the highly specialized teams that are laser-focused on denial prevention for the entire hospital revenue cycle. Through Melissa's teams, BLS Revecore offers a comprehensive analytics-driven denial prevention program that combines the highest success rates on the back end with sustainable, long-term denial reduction on the front end. Our second speaker is Linda Mescher, Director of Operations at BLS Revecore. Linda has more than 25 years of professional experience in both healthcare delivery and hospital revenue cycles. For the last 21 years, her focus in the revenue cycle has included hospital denial recovery and prevention and contract management. In Linda's current role as Director of Operations, she is responsible for a multidisciplinary team of nurses, certified coders, and skilled analysts that are dedicated to the resolution of payer denials for large healthcare systems. Speakers, if you're ready, the floor is all yours.
Thank you, Trevor. So welcome to the Denial Prevention webinar. My name is Missy Harbert, as Trevor mentioned, Executive Vice President of Operations. And I also have with me Linda Mescher, who Trevor introduced a few moments ago. So I'm going to start off just by giving you a really quick, brief background of who we are and what we do. We've been in business for over 24 years, exclusively focused on identifying and collecting underpaid and denied claims for hospitals. Our sole objective is to ensure our healthcare providers are appropriately reimbursed for the care that they provide. So in today's session, we're going to discuss how we can identify the root cause of denials, creating a multidisciplinary denials team, and successfully facilitating the prevention and overall reduction of denied claims with an analytics-driven program. At the end, we're going to take just a couple of moments to review some case studies where we can demonstrate how you can use actual live cases to help identify the fail points within the revenue cycle system. So to get started, just kind of walking you through at a high level on the path to denial prevention. Again, we're going to spend time walking through how we diagnose and define what those problems are, how we're going to track and trend them and develop best practice recommendations to mitigate and reduce those denials, and then utilize key KPI-based monitoring to help facilitate those reduction plans and the prevention plans for the denials within the revenue cycle. So some high-level objectives, again, for the presentation today is we're going to spend a lot of time, sometimes going over and defining and standardizing the root cause for each claim, because we find that that's a really key, important part in the process to get that all standardized across the board and what really caused the denial. And then identifying denial trends through root cause and reporting. So we're going to spend a little bit of time talking about how those root causes lead into the reporting and the analytics that will help you know where to look and where to start your process. And then we're going to talk some about identifying those key stakeholders to own, develop, and implement the best practice recommendations that you've decided as a group that you're going to put in place to mitigate and reduce those denials. We'll also talk a little bit about short and long-term monitoring through evidence-based KPIs. And then Linda's going to touch some on identifying the strategies for overturning and resolving denials, as well as some of the key, what we believe the key components that make up your denial team. And then we'll spend quite a bit of time today talking about the key strategies for that whole prevention piece. So we're going to talk a little bit about collecting the denials and how best to get that high success rate, but we're going to spend quite a bit of time on that prevention piece, which we believe is core to work it at both ends to really reduce your overall denials for your facility. And then at the end, I think I mentioned before, we're going to have some real difficult denial situations, and we're going to kind of walk you through that from both a clinical, maybe a coding perspective on ways that you can prevent that type of denial in the future. So just some overall general statistics. Becker's, we pulled from Becker's. We're still, as an industry average, running anywhere between 7 and in some cases 10% of the hospital's revenue is tied up into denial. So we all know it's a big problem for all of us. So hopefully today we're going to focus on some ways that we can tackle that. Some more statistics here. About 2/3 of the denials that we see are avoidable or what we might consider preventable. So we're going to talk about those statistics as well. And an interesting statistic here is that the cost of the denials and what it costs to revenue, or what it costs to healthcare systems. So approximately 3% of their net revenue stream can be tied up into working or overturning or collecting or just writing off those denials in some cases if they're not able to overturn them. So that can definitely make a difference between a negative and a positive on your balance sheet. So I'm going to move in kind of into some of the key components of the webinar today, and we're going to start off by defining and standardizing the root cause of your denials. So I think it's really critically important to have like a 2-tiered base denial root cause categorization. And it definitely makes sense, and I know most providers do that, what we call a high level, first level, broad category, which may be very similar to your CARC or ARC codes or your remark codes from your payers, where they may just give you a general category that denial falls. So being able to log that in your patient accounting system and report on that at a high level, for instance, authorization, medical necessity, non-covered, that real basic level. But even more importantly, what we think is that's fine at a high level, but then taking that next step further to really look at that, what we call a second level detailed denial, which is typically assigned based once the claim is reviewed and you're looking at all the available information, whether it's, the EOB, from making the phone call to the payer, reading through notes, but having a much deeper second level code that will really kind of put a finer point on why the claim denied, not necessarily just what's on the CARC and ARC code. And then making that somehow scalable so that you can repeat the training of associates that will be applying that, because I'm sure you all know, as you're working through your revenue cycle process, getting your data standardized across the board, especially in those areas where you've got some manual intervention from either your denial analyst, collectors, or maybe even some of your clinical folks. Updating those codes manually is going to be really important to have some repeatable, scalable training that you can do to try to keep those codes so they're all applying those consistently across the board as much as you can. If your system has that ability to build some decision trees into the system to help them decide on which second level code should be picked or applied to a claim, that's the best case scenario that will ensure that you get a lot more standardization, but certainly the training and tools that you can provide will help as well. So I don't think I have to tell anyone on this call probably today that that standardization is going to be the best way to really clean up your data and make sure that you're comparing across all facilities and date spans. And so it's just an ongoing process of keeping that data clean. Some other just high-level things when it comes to root cause analysis and reporting, and we'll walk through some samples of reports, but identifying those denial trends through root cause, we believe that the best way to do this is that all of your reports should really reflect both the denied claims in dollars as well as volume of the accounts, and not necessarily just the claims that you may recover and get paid, but taking a real good look at those claims that you're not able to recover as well sometimes can be as important into the whole prevention piece that we'll talk about later on. Making it repeatable so that high-level views can be reviewed and established in intervals. So setting up the reports that you can customize, but then make them repeatable so that you can do them frequently and not a whole lot of manual intervention may be required there. So one of the nice things that we find are essential as well is having that ad hoc capability so that as you're trending out your numbers, whether that's by root cause or by payer, but having that ad hoc capability within your data warehouse or whatever you're using to report on your denials, to be able to take a deep dive at one click is really important, because as you'll see as we go through the whole prevention piece, that's what we find is really instrumental in looking at the high-level trends, but then being able to dive into that claim detail to select some of your cases to do your case studies later on that we'll talk about. And then, of course, distributing that to your key stakeholders there as well. So next on the screen, this just gives, there's lots of ways you could slice and dice your data, but this just gives a high-level categorization where it can give you both that dollars placed as well as the volume of accounts. And this gives you an idea, too. This slide can point to a little bit of what I mentioned earlier on about having that second-level root cause code that is deeper than just that the claim denied for no authorization. You might set up codes that really drills down and tells you why the authorization was not obtained, whether it was a coding conflict, if they requested it but then submitted a cancellation, maybe the data service conflicts. So whatever it is there in that second level, that's going to be really gets in that granular view where you can then pull it in to work through your prevention program. And the same thing on the medical necessity. And we all know authorization, medical necessity are probably everyone's top denial category. So this section on the medical necessity just some ideas of doing that second level deep dive categorization where you could really look at just denied days, because you might want to take a look at those separately, or admissions that didn't necessarily meet the MCG or interqual or whatever the payer's criteria might be. So you can really take a look at those admissions that are coming in that didn't meet qualifications. Level of care, that's another one. That's always a good one to break out that way. So you can take a look at that later. So that just gives you a kind of an idea of how those second level denial codes can be used. And this is just a slide where I think we all know, but that domino effect, I think one of the things as we help our clients as we work through the prevention program, sometimes I think we all, and myself included, can sometimes want to bite off too much at one time and try to fix everything or too many things at one time. So our experience has really been to take a look at the data and just really knock down the tallest trees. So whether that, it's not always by dollar, although certainly it can be, but maybe even picking one or two, sometimes three a quarter, things to really dive into and take a look at, do some root cause analysis, some case studies on, to really work on putting some type of prevention in place on just a few things at a time, whether that's in dollar or maybe in volume, or in some cases, things you could fix internally versus things that you may have to involve your payer relations folks in to get that fixed. So we'll talk also a little bit about identifying those key stakeholders. As you you get your code set up and you get your system and your reports and your analytics where you can really trend out and know where your denial issues live and what's happening, why they're denying. Now you're getting to the point where you want to really develop the key stakeholders that are going to come to the table and help you collaborate with all different areas of the revenue cycle, because as we know, it's not all just in patient PFS, although that's usually the folks that are tackling and working some of the denials. It's not always just them that it'll take to really prevent and reduce that going forward. It might mean that you need to pull in folks from all different areas, whether they're under your team or not. And as we all know, lots of times those clinical upfront folks are not necessarily always under the same umbrella of report structure. So it might take getting cross-functional teams to come together for that, to form that committee to really work on that prevention piece, and making sure that the folks that you bring onto that committee and those stakeholders have authority to make and implement changes, as well as that mix of experience. I have found that it's always super helpful to have some outside eyes, some people that maybe are good at thinking about things and what is wrong and what could happen and what you could do, but then you also need that group of folks that are really just good at keeping track of actual making the changes and diving in and looking at the claims and implementing some of that change. So getting that right mix there, and that mix between clinical and revenue cycle is you'll see later as we do the case studies, I think extremely important as you work to set up your committees for this prevention piece. So here we're going to talk a little bit about KPI-based short and long-term monitoring. So it's all things we've already talked about so far in the presentation, but really pulling together your data, like we mentioned, doing some analytics on your denial data, and creating some dashboards so you can track and trend things as they're getting better or getting worse, or each month, if you trend things, say, by discharge date, not necessarily the date the denial came in, you might be able to more easily see when things broke. If it's something internal, when maybe a modifier, didn't get added to a claim, that might trigger some of your billing and coding type denials. Maybe you had a changeover of your concurrent utilization review nurses up front that may have made a difference in some of your numbers, whether that's positive or negative. But then really just looking at intervals, set your intervals, and then look at your false positives as well, spending a little bit of time on those to kind of strip those out of the noise out of your data so you can really get good, clean data that's standardized across the board on how it's coded and trended, but then removing those false positives so you can really just look at the true denial data. And then being open to change, because I find almost always that as you set out to really engage with a denial prevention program, what you start out and what you think you're going to work on, being open to pivoting and changing as you go, because what you find is the more you dig in, I always find that we end up changing direction or deciding to take another course or a different path as you start looking at the data. So just being open to not changing so much your direction that you can't stay focused, but definitely letting the data drive you to where you need to look and where you need to go. So from there, I'm going to turn it over to Linda Mescher, my counterpart, for some of the more in-depth review of the program.
Yes, thank you, Missy. Good afternoon, everyone. So I'm going to pivot a little bit and talk about denial prevention and denial management. And you'll hear a little bit of a mini theme in what I'm going to talk about, and it speaks to Missy's point a little bit, and I'm going to get to that kind of early on up here, but it'll be a little bit of a thread throughout. But in the way of denial prevention, first and foremost, one of the key components of that is your strong case management program. And right up front, here's the key I was talking about. It's having those clinicians with the in-depth revenue cycle knowledge where they're familiar with both sides of the process, both the in-depth clinical knowledge and then the revenue cycle, to be able to attack the cases from both perspectives and make sure that the complete picture is handled, and when things don't quite go the way we want, knowing how to resolve those issues. And those clinicians having the advanced carrier criteria knowledge, your MCG and your interqual is very important to have the thorough application of those according to the case. And then for patient status verification, getting patient status correct obviously is a huge component and leads to a lot of denials if it's not quite done right. So some of the options facilities use are having that clinical presence in the emergency room, so where you have staff right there getting the up-to-date information on patients as they're presenting to get that status correct right from the beginning. So if you're getting it correct early on, you can hopefully avoid those situations where you have a condition code 44 situation or some such thing. So that's one option. And then some facilities also choose as a different alternative to have a separate department that just handles all the status determinations for the different facilities. So they're really just experts in that, in knowing the criteria and when patients meet medical necessity for inpatient versus when they should just be observation, and being able to get the right status up front kind of from that department's perspective and in sort of an off-site but centralized area. So a couple options for that. And then another component of a strong case management program, those inpatient-only procedures. And as you all may be familiar, it is up for discussion. This may become a non-existent thing here in the future. It's up for discussion right now, but currently we still do have the inpatient-only procedure list for those Medicare claims. So you definitely want to get any planned procedures, get your CPTs from the surgery scheduling area at the outlying offices. There's no reason they shouldn't be able to provide those to you all because, you know, that's what those physicians use to bill, so they should absolutely be able to provide those, and then compare them definitely up against that inpatient-only list to make sure those procedures are statused correctly. One thing that I've seen happen, fortunately not a lot, but sometimes for teaching facilities, you can have the best process in place. You have your CPTs identified. You have your inpatient order when it's appropriate. The patient gets their surgery and then goes up to the floor afterwards with their perfect little inpatient admission order. And then you maybe have a resident or somebody that thinks, wow, I've had some training around this, and I think this patient should be outpatient observation, and your order gets changed. And those claims can go out the door as, you know, so you've done everything right, but now you've got an outpatient observation claim. So keeping kind of tabs on that and making sure that inpatient order stays on the record is important as well. Okay, so admission is critical, however, also continuing to follow that stay throughout the admission to make sure the patient continues to meet the criteria for the status that they're in. So if they were in observation, outpatient observation, and they had some complications, definitely making sure that that order gets changed to inpatient, because if you are providing inpatient level of care, you definitely want to get the reimbursement for that care that you're providing. So following the patient throughout is important to do. And then having clerical staff that really back up your case management program. They can keep track of those clinical reviews that get sent to the payers, make sure they've made their way there and have been received so that you don't end up with a no clinical reviews received denial, as well as if they have received the clinicals, what's their response? We need to know whether it's approved, denied, and that sort of thing. So having someone that can track that and provide the information back to the case managers so they can follow up accordingly is needed. having physician advisors available for your case management staff. There's times when perhaps the criteria, the MCG, the interqual criteria would suggest a patient is one status, but the attending physician doesn't agree. So having a physician advisor available to help work through those cases can be beneficial. And then as well, if your attending physician and case management perhaps agree, but now your payer says, no, I don't agree with you, a physician advisor can be put into place for a peer-to-peer situation to help facilitate that process if your attending physicians are either unavailable or maybe unwilling to do that peer-to-peer call. Your physician advisor can help intervene in those cases. Okay, this is just a poll that was done by HFMA of some hospital finance professionals, kind of asking what are your biggest challenges in the way of denials management. So you all may or may not be able to relate to some of this, but I'll just go over the top couple. So gaining cooperation from clinical departments to resolve those root causes was tied for first place with the concept of working with payers to meet in order to kind of review what are the issues, what are the trends, what do we need help from you to overturn denials that we're having problems with. So those were the biggest two, and the others are just a mix of what's a clean claim and when must it go to appeals, and managed care contracting collaboration, and then charge master rules. Okay, so we have our denial prevention that we've talked a bit about. So you can, unfortunately, you probably all experienced this as well, where you've got your ducks in a row, all of your T's are crossed and your I's are dotted. You've registered the patient correctly, you got the right status, you have the billing correct and the coding correct, yet you receive a denial. So as good as you can have your prevention, you still need to have a solid staff set of folks in place to address the denials when they do happen. And here we have our theme again. It's that strong clinical representation in your denials and appeals area with very strong both clinical knowledge, and then that revenue cycle knowledge again comes into play. So knowledge of not only the criteria themselves, so interqual, MCG, your NCDs, LCDs, and your payer-specific policies, but knowing when to apply which one. And if they're conflicting, which one supersedes when you have maybe a Medicare Advantage payer where you could potentially have both payer criteria and your NCD and LCD situation. And it is very difficult to find folks that have this expertise. So I know some folks do decide to outsource this piece of their business and revenue cycle, but whether you decide to insource or outsource, it's definitely something that's needed for your facility. And then again, in your denials area, you absolutely want to support your clinical staff with some solid analysts and some clerical staff so that they can take care of some of the administrative pieces and maybe submitting the appeals and tracking them afterwards, so that it allows your clinical staff with all that expertise to apply it in the areas where they really need to focus. And then having some legal input in your denial and appeal team is very helpful. If there's some contract interpretation matters, they could assist there. Perhaps there's some statutes that might be involved that they could lend a hand on walking through. And then just for some general assistance with persuasiveness in the letters, formatting of the letter, just getting that persuasive factor and effectiveness enhanced. And then, as Missy kind of mentioned, in a kind of a couple different ways, really having staff that are skilled at that root cause analysis, really digging through and figure out where did this fall off the rails, where did it really fall through, so that that information can be analyzed and fed back to the appropriate areas to address and resolve the issues so prevention can take place. Definitely knowing the contract is important for your denials management staff. Very often times there can be denials for certain situations, and then when you look in the contract, they really can't shouldn't have done what they did. One example may be denials for authorization. Perhaps they are upholding something administratively when the contract says in cases of administrative denials, that denial will be overturned as long as medical necessity is met. So sometimes you have to provide that portion of the contract to the payer in an appeal to get them to overturn that. And similarly with appeal time limits, very often, this one happens probably more than the first one, but we can get denials upheld for exceeding filing limits, and then when you look at the contract, it specifies something different. So you do need to be aware of what you're entitled to based on the contract and utilize that to the extent you need to. And then having input and support from your managed care to work through any of those times where the contract isn't being followed so they can provide some intervention there with the payers. State statutes, you want to be familiar with what might be applicable and with the plan. Is that plan fully funded or self-funded? Because that can definitely mean different things as far as appeal time limits and, ERISA, different things like that. So you want to be familiar with the type of plan you have and the state statutes that might be applicable. And we can't get away today without talking a little bit about COVID. Just providing a little bit on how during this pandemic, some things we can do in the way of denials and appeals that might help you. Because of COVID, certainly staff has been reallocated. So people that used to be doing certain functions have been moved to doing something else. So denials can certainly still happen during the time of COVID on all claims, not just necessarily COVID claims, but any claim can be affected by the pandemic. So just a few things here that are perhaps some tips or suggestions on ways to combat denials you might receive. So this first one is a Medicare waiver, and CMS issued this waiver, and it instructs the MACs and the QICs that they can allow flexibilities with appeals during this pandemic, and this is only in effect, of course, through the public health emergency. But during this time, you are able to go ahead and submit appeals, even though they don't have all the required components that they normally would. Or if you're submitting just beyond the appeal time limit, the MACs and the QICs do have the ability to still review those. But something to keep in mind here is that just because they have the ability to be flexible, this doesn't mandate that they have to be flexible. So your best practice will be to have the complete appeal if possible and on time if possible. But if you can't, you certainly can still submit those, and hopefully they'll be reasonable and allow those flexibilities. And then if you have a situation where you don't have a managed care plan or a fee-for-service, perhaps you want to look at what your provider manual might say. We've provided here one example of a provider manual that does allow some ability to tap into some flexibilities, and we will use this for payer or providers, that are struggling a little bit with timely filing. So this example is from Ambetter, and Ambetter is present in a number of states. It's either 18 or 19 or somewhere in that neighborhood. So you may have plans in your part of the country, but some of the Centene plans have similar language in their provider manuals, so you may want to check it out. But this particular provider manual does allow for flexibilities in time of catastrophe. And I think we can all agree that COVID has presented certainly a catastrophic situation for some providers more than others, but you are able to use this in your appeals, and you do have to request it, though they will not offer it to you. You do have to request it. But just something to keep in mind, that look at your provider manuals and even your contracts and see if there's anything in there that you can use that will help out in this way. And then for situations where you don't have a waiver and you don't have a provider manual that helps you out, don't be afraid to, within your appeal, request flexibilities. Whether it's authorization, medical necessity, or timely filing, those kinds of situations, you can just request that they be flexible due to the impact the pandemic has had on the operations of facilities. And we've just provided here one example for you of some verbiage that we use time to time for, like, the situation here is authorization denials. as one example, but you could come up with something similar for these different scenarios. Okay, so enough about COVID. So if you have done everything right, as far as you're concerned, the denial should have been overturned. Either it shouldn't have happened in the first place, or maybe something happened and now you've appealed it and it's not getting overturned. You do want to know what your options are in that case. And here again is, hopefully it'll be the last time I mention it, but again, having that right staff that knows when is this situation one where we really aren't going to accept the determination of the payer. It's a really strong case. It met everything. It checked all the boxes. It really should have been paid. So knowing when to escalate is part of the equation, and then knowing what your options are for escalation is another component. So the first place I would start, though, in that situation is generally try to work with your carrier, try to work with a provider representative, and see if you can come to an understanding, and utilizing your managed care staff to help out in that manner as well, and tap into that relationship. You may need to follow any arbitration process that would be involved there, but then if you don't have resolution there, you do want to be familiar with what your external appeal options are. So whether in your area, in your state, that might be Department of Insurance or whatever it may be, you'll want to know what those options are for you. And then, of course, certainly if you have a big enough trend, a big enough issue, you can definitely involve your legal team. This subject, line item denials, we'll talk about this just momentarily. Many of you probably are experiencing this where the different payers are partnering with third parties to, such as Equian or Cirrus and those type of companies, to do line item denials on claims, a lot of denials for bundling and various issues. So it's definitely a pain point for a lot of people. But some of the things that we've developed strategies for this, but some things we'll share are that you definitely want to know what your contract says. What does your contract say about your definition of billed charges, and what does it say about how they're supposed to reimburse? Because when they are denying that many items off of your bill, it really creates a material change to your contract essentially. So. But you'll definitely want to follow appeal processes and go through that first and provide all the things they're asking for, provide the documentation that they're wanting, and absolutely supplement that with references, with any billing guidelines, or whether it might be the Medicare provider reimbursement manual or uniform billing editor, but go ahead and use the references that support why you're billing, how you're billing, and that you're entitled to bill that way, and that the reimbursement portion is really driven by the contract. And then if you aren't having success or aren't having enough success, you may have to tackle that from a legal perspective, unfortunately. Okay, we'll go ahead and move to the case study portion. And I will walk through the inpatient kind of component of this, and then Missy will talk about the outpatient, from the outpatient perspective of the case study. But we did this case study with a large 10-hospital health system that has some additional number of freestanding facilities. And in this case study, we identified areas of improvement both in outpatient authorization and inpatient medical necessity. And we did root cause tracking, and that was implemented by encounter location. And the root cause denial tracking was implemented by payer and by discharge date. The case study did highlight fail points on inpatient admissions, and I'll talk about that a little bit and some of the things that were found. And then there were focus groups and that were developed in order to address these fail points and to get action plans in place. Okay, so the inpatient study, this is a format we like to use. I know this is quite small for you, but I'll kind of walk you through it visually. You don't really need to see all the detail here, but just know that the first 3 columns here that you see are where we typically like to lay out the admission detail, kind of the clinical summary, and some of the authorization and denial detail in those first 3 columns. So we look at it and we take one case that's representative of one of the larger denial areas that exist, and we will just really lay it out in this format, and we just slice through it and really hammer through and find out all the details, and that's where we lay out it in the first 3 columns. And in that 4th column that's a little shaded is where we put our kind of like the fail points that we identify and then some of our suggestions. And then in that last column is really just the appeal outcome and, you know, the results of our appeal that was done on that particular case if it's one that we handled. But this is the format that we use, and then out of this I'll go into some of the fail points and suggestions that we had, and that's what's on this slide. So one of the things we had found was that there were issues with some copying pasting of physician progress notes. And then when that happens, it can be hard to include all of the detail of the patient's case and really convey any changing medical necessity to the payer. So this can be a concern, and for this, there was some education done by the UN Steering Committee to help address that portion. There was also noted to be some incorrect interqual subset selection, so this is something where the case management department was utilizing a different subset within interqual that wasn't necessarily the best one and didn't allow for the best analysis of the case. So there was some education that was implemented for the criteria and how to utilize it in the best manner that's going to help their facility. There were some gaps in communication identified with some on-site staff that were present, so there were some action plans put in place around that. There's also noted to be a denial letter that was received, wasn't routed to the case management department, so that didn't allow them to then either set up some sort of response or address that in a timely manner. And then also at one point there was an option for a peer-to-peer, and that wasn't done, and so a physician advisor plan was implemented to cover that whenever an attending wasn't available, you know, and sometimes they're not willing, but if a physician advisor can be on standby for that to fill in, that's what we had discussed with this facility. And with that, I will turn it over to Missy for this outpatient perspective.
Sure. Thank you, Linda. So from an outpatient perspective, case study, I've got a couple of examples here that I'm going to walk you through where we, again, like Linda said, we took that data, it was identified certain key areas that had the issues with the authorizations and reviewed the claims and used them as case studies to come up with some fail points that we've identified from an outpatient perspective. So in this case, one of the main trends that we found for this particular carrier was where a commercial carrier had released a policy update that was limiting the drugs, certain drugs, not all drugs, site of care provisions to be only maybe the initial dose or some exceptions if the patient had issues with tolerance or a safety issue. But the carrier's policy would allow the initial dose, but then subsequent doses needed to be transitioned to the home infusion or ASC, where they would get the subsequent doses later. And what we were finding is they would come in, they would get the initial dose authorized, but the subsequent doses, it wasn't caught that those subsequent doses need to be in a different site of care for that particular carrier's medical policy. So what they did here is they worked with the IT to set up a mechanism where they would catch those subsequent doses just for certain J codes, because it wasn't every J code affected, but we narrowed it down to about 3 different J codes that were really targeted. So we were able to set up a flag for subsequent doses that for this particular payer that would get flagged and set up where alternative arrangements could be made to, get the drug in a different setting. So that was one of their biggest issues that they had from an outpatient perspective for some of those infusion drugs in particular. And the interesting part is that it was just really one carrier in that particular area that was making those site of care provision changes in their policy. So it, as you can imagine, it was quite confusing for the hospital to be able to set up so many different guidelines and rules, for each payer about who can come in and who has to go elsewhere. So it was a way to kind of use that technology to leverage that to help them mitigate that. And then the second highest issue that we found as we were diving into the outpatient case studies and samples was really it was more of a payer issue. And this is, I'm sure you all have seen this with multiple payers. It's not always related to just one. In this particular instance, it was two commercial carriers who used the independent parties to do their authorization reviews. So authorizations were obtained by the hospital through this independent party. Authorization was secured. It was added to the claim and billed on the claim, but the claims were still denied for no authorization because that independent party wasn't linking the authorization numbers over to the claims payment system. So in this instance, we helped them identify the two carriers that was the primary issue, and it was a trend issue. It wasn't just one or two here or there that would, not always come across that there was something wrong and that would cause it not to come across. It was a real pattern and a trend. So in this case, we involved managed care to get the payers involved and showed them the data. And not only did they retro review the affected claims and re-adjudicate for payment with interest, but we really helped provide the analytics to show what types of claims or what part of the claim maybe was getting caught where the authorizations were not coming over to try to help them mitigate the problem so it would not continue going forward. And I can't say it took the payer, I would say it was longer than we would like. It took them roughly about 6 months to really fully identify what was causing that to happen and put a couple of fixes in place that didn't necessarily solve it, but then eventually we got to the root of it and were able to help them fix that and get that resolved for them. Not 100%, but I would say it resolved it at about 80, I think it was 82% of those denials stopped occurring. It would still come through occasionally. But then something else like trending like this, so when you really have all of these key components to that prevention program where you're not only appealing the claims like Linda talked about with the appropriate criteria, having that strong clinical, especially on the auth and medical necessity type denials, where you're going to have like a higher than normal success rate on the back end, where you'll collect the dollars, but really putting just as much effort into that prevention piece where you can walk through, peel the onion back and really try to determine what's causing them and work to decrease those. You can see significant results. So we had a client that we were engaged in, and it took us about that first year. We did some prevention, but it certainly wasn't at this rate at all. But well into the second year, because we had been focusing so much on one of their primary payers, which was Anthem authorization denials, and some of the case studies that we talked about, we were able from 18 to 19, you can see, and these are gross charges, but the Anthem only authorization denials for just the top 6 detailed root causes, we were able to help them reduce the denials coming in the door from almost 13 million down to 4 million. Over a course of about a year of working through all of those detailed top 6 reasons. So it can make an enormous difference when you're working it from both angles, from the front end and the back end. So just to kind of highlight some final considerations that we've sort of talked about through the program are those best practice for denial prevention. So just to kind of recap is that thorough tracking and training of your denials so you know where they are occurring. Using that root cause consistently, whether that you have to do that manually through training and auditing to make sure the codes are being consistently used across the board, or if you're able to automate that through decision trees, whatever your capabilities are within your organization, having that standardization so you can track it all the way from the front, from the time the patient walks in the door to the back end of where that might occur. And then having that denial prevention and resolution team with those key individuals and skill sets that's really going to dig in and look at all the key areas that might be causing the denials and addressing those from an organization-wide approach with tying a heavy consideration on tying the financial and clinical factors together and where they intersect, because that's typically where we find a lot of that is, and those are different areas within the hospital. So having that heavy consideration right where those two things intersect together, we find is extremely important. And then before we get on to the question and answers, we did save just one other case study that we thought we would highlight, not particular to actual claims or patient cases, but a decision that we watched one of our clients as they made decisions on what to do with their denials and what they should do to try to really increase their cash flow and prevent the denials going forward. So this was a case study that we had the pleasure of being involved in and still are involved with, that had always believed in outsourcing their denials, and they had one vendor that they outsourced all of their denials across the board. And that vendor was fairly successful, had a pretty solid program, but they just felt like there was more that they could do from a prevention. They felt like there was more from a cash recovery perspective. So they decided to make a case and create some competition and do an alpha split between two separate vendors on that same book of business. And through that competition, and both vendors had to report up the denials in a very same root cause codes, very uniform. All the reports were merged together. And after about 14 to 15 months of merged alpha split, what we found was, this is super interesting to me, because what we found was that one hospital system that consisted of 5 or 6 different hospitals collected over double between the two vendors as what they were collecting when the one single vendor had the full alpha split. So one vendor collected more than what the single vendor did for the entire time period across the board for all of the denials. So that to me really was a telling story, that competition, one, we learned from each other, both vendors competed, and then they learned what denial. So if one area would miss something, the other side might pick it up, and we shared information back and forth. And it really opened my eyes to a great solution. If outsourcing is one of the things that's on your list of considerations, creating that type of environment, I think, was obviously very beneficial to the hospital as far as cash flow goes, and continues to maintain that high level of cash acceleration for their denials. So I thought that was a great case study there to walk everybody through. So other than that, I believe that concludes the end of the presentation, but we do have a few minutes left. We can open it up to questions or go through any questions that the group may have. I do know one person had, one of the callers had asked the question early on in the presentation if we were measuring denials against gross or net revenue, and that is net revenue is typically how we measure that too on those percentages. Any other questions, comments? That's all I see on the chat on the question and answer. Okay. Well, if there are no other questions, Linda and I appreciate everyone's time today and giving us an hour of your, I know, very busy day. So we appreciate your attendance and your attention there. Thank you.
All right, very good, very good. With that, on behalf of AHAM, thank you for joining today's program, and a big thank you to our speakers for sharing their expertise. I'd now like to direct your attention to the survey that I'll bring up on your screen momentarily. We appreciate your feedback. This does conclude today's session. To end, you may simply hang up. Have a great day.